Sanchez-Ramos. Welcome.
We had, starting this year, Marilyn had asked us to pick. She gave me a list of topics. So for the Ask the Doctor session, each month we'll have a different topic for the first half hour, and then we'll take questions that may be related to what I speak about. So the first topic appropriately is how to make a diagnosis of Parkinson's disease. How do we go about making a diagnosis? And I always like to begin with a kind of historical perspective on this condition so that you'd understand how we nowadays make a diagnosis. Well, many of you know that the illness was named after James Parkinson, a physician of the early 19th century. Remember, we're in the 21st century, so it's well over 200 years ago. The interesting thing, how did he make the diagnosis? He didn't call it Parkinson's disease. He was the first person to write a little description of what he called the shaking palsy. That's what he diagnosed. And you know what? He made that diagnosis in people that weren't even his patients. Walking down the streets of London, he would notice some people with small shuffling gait, slightly stooped posture, very slow in their movements, and with a tremor. And he described beautifully the small steps, the stooped posture, and the tremor. And he gave it the name the shaking palsy. Described the 5 cases in detail that he observed and followed. Remember, this is just him observing in the street. And bring it now to the 21st century. We also make the diagnosis based on observations, a pattern of signs and symptoms. But the important thing to note in terms of terminology is that he called it the shaking palsy. Palsy is an old English word that we don't use anymore, other than in Bell's palsy, you've heard. But palsy just means weakness or paralysis. It's an old English word that means paralysis. What does paralysis mean? It means weakness of muscles. So people who are paralyzed either are very, very weak or they can't move at all. Most commonly, paralysis comes from a stroke, where there's damage to the brain due to poor blood flow to that part of the brain, and people have permanent damage in the part of the brain that controls certain movements. But he noticed that the shaking paralysis was very different than most paralysis. So he called it, it's a very type of paralysis, very specific type. It was a shaking paralysis. And it went with that name, the shaking paralysis, up until around 1860, when this French neurologist, who was the father of modern neurology in a sense, named Charcot, he decided to call it Parkinson's disease in honor of James' seminal description, even though he didn't know what caused it, had never looked at a brain of a person with Parkinson's disease, never treated it. But by the time that Charcot and then other neurologists in Europe, especially Northern Europe, began to see more and more cases of the shaking palsy, because it seemed like the incidence and frequency started just going up very high. And it was with the advances in the Industrial Revolution, a lot of pollution in the air, and many people began to think that this illness may be environmental. James Parkinson thought it was probably an emotional disorder. And for a long time it was considered a neurosis, even up until the beginning of the 20th century. A neurosis was a term used by Charcot. Charcot was the teacher of Sigmund Freud. And you know, Sigmund Freud believed everything was due to problems with development in childhood, often sexual development, etc. But neurosis was a term used to signify a neurological deficit that had no anatomical or other explanation. So there were people that had neurotic paralysis, and that would be just, and they attribute it to hysteria. there would be all kinds of motor and sensory problems that psychiatrists would see that they could not explain in terms of known concepts of pathology. So they called it neurosis. And Parkinson's disease was considered a neurosis because when they looked at the brains of people with Parkinson's disease in the 19th century, they couldn't see anything abnormal. The brains looked perfectly normal. They looked just like age-matched, healthy people. And it wasn't until 1950 when the ability to measure different chemicals in the brain became available. And with the development of drugs that would be used to treat psychosis, there was an observation that those antipsychotic drugs mimicked, the effects of those drugs mimicked Parkinson's syndrome. Now, I threw in another word, syndrome. I didn't say Parkinson's disease, but Parkinson's syndrome equals Parkinsonism equals something that looks like Parkinson's disease. So how do we put it all together to the contemporary times? Well, how we make the clinical diagnosis of Parkinson's disease is by observing for the signs and symptoms of a Parkinson's syndrome. And there are 4 cardinal signs that we look for, signs and or symptoms. The difference between a sign is and a symptom is that the symptom is what the patient feels and conveys to the doctor what bothers him. This is my symptom. I shake, or I have a hard time walking. Those are symptoms. The signs are things that the examiner, the physician, will observe or detect when doing a neurological examination, watching how you walk, testing the rigidity of your arms, having you perform different movements, etc. So the 4 cardinal signs for Parkinson's syndrome are the key elements for making a diagnosis of Parkinson's syndrome. And I'll tell you what Parkinson's syndrome can be divided into. The general category of Parkinson's syndrome is nothing but slowness of movement. There are many things by itself that can cause slowness of movement. Rigidity. Patients often won't notice the rigidity, but the doctor does. Usually it's a certain kind of rigidity we call cogwheel rigidity. It feels like a ratchet wrench at each joint. And rigidity for the neurologist, because the neurologist sees it as a sign, is resistance to passive movement of the arm across a joint. So if I'm moving your arm, flexing and extending it, and it seems to catch, and it's like I'm struggling to open it, it's stiff. That's called rigidity, and that's a cardinal sign. So slowness of movement, cogwheel rigidity, that's 2 of the signs. The third would be intermittent rest tremor. It's a tremor that's present when you're doing nothing and not activating any muscles. So if I'm just standing here, if I have this tremor, I'm not activating any of my arm or hand muscles, but you see this little movement, that's called the rest tremor. If I reach out, the tremor disappears in classical rest tremor. And that's one of the third sign of Parkinson's syndrome, is a rest tremor. Now, a tremor that's only present when I use my hand, but then if I'm not doing it, is gone. That's called an action tremor or postural tremor. And that's not a sign of Parkinson's syndrome. That's a sign of essential tremor, which is a whole other category of illness. So many times people see a tremor and assume it's Parkinson's disease, but it's very important to notice that the classical sign for Parkinson's syndrome is a rest tremor, not an action tremor. Now, there are some people that have both rest tremor and postural and action tremors because essential tremors are very common, and it's not too unusual to have a person with both Parkinson's syndrome and essential tremor. In addition, postural tremors are very common in people who take a lot of bronchodilators or psychomotor stimulants will cause a fine tremor. So if you have COPD and you're taking bronchodilators, you'll develop an action tremor. Many drugs cause action tremors. The 4th cardinal sign of Parkinson's syndrome that I use is the tendency to lose one's balance without any other explanation for the loss of balance. Everyone has problems with balance at some time in their life. But in Parkinson's syndrome, the loss of balance is not due to weakness, because there's no decrease in individual limb strength in Parkinson's syndrome. The loss of balance is completely due to the inability to retain postural stability, and it's due to a deep brain, gray matter derangement. And it doesn't happen in the beginning of the illness. So when I get to refine what I mean by Parkinson's disease versus Parkinson's syndrome, the time course of development of these 4 cardinal signs is very important in distinguishing, for example, lower body Parkinsonism from idiopathic Parkinson's disease. Since lower body Parkinsonism occurs in about 10% of all cases of Parkinson's syndrome, I should talk about what that means. So you know that if I see someone who's walking in with small steps, narrow base, and one arm doesn't swing as much, and they turn with several steps, and have decreased facial expression, you could get a gestalt that it's going to be a Parkinson's syndrome. Now notice I didn't talk about small handwriting, problems with swallowing, low speech, decreased facial expression, because those are not the cardinal signs. Those are secondary signs that are due to the primary signs. So a person with Parkinson's syndrome will have a whole bunch of other features that make it very clear that they have a Parkinson's syndrome. You'll see a very serious expression, lips partly parted, decreased frequency of blinking, soft voice, sometimes stuttering voice, and a whole bunch of other signs and symptoms related to the autonomic nervous system, etc. But those are not how you make the diagnosis. The diagnosis is made of Parkinson's syndrome, because that's the first step. Do you have Parkinson's syndrome or not? Because that's the first step in making a diagnosis. And to say that a person has Parkinson's syndrome, I just need 2 of the 4 cardinal signs. Because it could be the very beginning of the illness. They may not have the full spectrum of the 4 signs. So if a person has 2 signs out of 4 of Parkinson's syndrome, we call it Parkinson's syndrome. And with time, we'll see if the other signs develop. But the signs could be, how can I say, may not include tremor, because about 30% of people with Parkinson's disease never even have tremor. The most common sign, it would be slowness of movement and rigidity. Now, loss of balance is very common, especially if you get over 70, 80 years of age. Balance becomes compromised because of inner ear problems, because of poor feedback from the peripheral nerves, poor vision. All of those things can contribute to imbalance. But if a person presents with the first symptom, they come into my office and they have decreased facial expression, they're slow in their movements, they have rigidity. The rigidity in the upper extremities is very mild. And their slowness in the upper extremities is not bad, they can still do buttons. But their first symptom, which happened 3 or 4 years earlier, was loss of balance. They began to feel unsteady on their feet. They were worried about when they were walking on the golf course, they had a few falls. And falling became the first sign that led to them seeing a doctor. And the doctor sees, well, there's a little bit of slowness, decreased facial expression. Maybe you have Parkinson's disease. But when I examine them, what I see is that their gait is very bad, but their arms are loose. And it's hard for them to get started. That's called lower body Parkinsonism. Usually begins with falling. If someone tells me their Parkinson's syndrome began with falling, it's typically not going to be Parkinson's disease. It's going to be an atypical Parkinsonism. If they tell me it began on both sides at once, it's not going to be Parkinson's disease, because Parkinson's disease is unilateral in onset. Always starts on one side. Eventually both sides are involved. And eventually falling develops. That's how classical Parkinson's disease develops. One side first, maybe a little rest tremor. That's it. It's only now and then. When there's stress, maybe a little rest tremor. Then they notice maybe my handwriting is a little bit peters out. It's getting smaller. And that's it. That's how it begins. And eventually, the other things, the slowness becomes more evident. And then within years, the other side is involved. Within 6 months or a year, the other side starts having the same problem. And then after 3 years, they notice that their balance is off. That would be how a classic Parkinson's disease develops. So now you know that I can distinguish Parkinson's syndrome that is due to a small, what we call lower body Parkinsonism. And the cause of that lower body Parkinsonism is completely different. How do we know that? Well, because if you examine the brains of people who died with a clinical picture of lower body Parkinsonism, the brain tissue is very different than people who die with classical Parkinson's disease. Number one is that in the lower body Parkinsonism, what you see is a lot of small strokes, microvascular occlusions in the white matter that you don't see in someone with idiopathic Parkinson's disease. Secondly, the loss of dopaminergic neurons is never as pronounced. The problem is destruction of the target cells in the striatum because of the small strokes, or disconnection of the frontal cortex with those deep gray structures of the brain. Whereas in Parkinson's disease, you'll see the Lewy bodies, which aren't present in lower body Parkinsonism. These are things you can only observe under a microscope, and it's considered to be the pathological hallmark of the disease, the presence of these abnormal proteinaceous materials that you can visualize under a microscope. They're found in the substantia nigra. They can be involved in other parts of the brain, and we'll talk a bit about Lewy body Parkinson's syndromes. We know that the classical Parkinson's disease pathologically has to have Lewy bodies present and loss of dopamine neurons, because when you lose dopamine neurons, you significantly don't have sufficient dopamine, which is a neurotransmitter that is critical for the normal execution of learned movements, that we do automatically. When you don't have enough dopamine, it's very difficult to automatically move. The same kind of thing can happen if I gave people a major tranquilizer, what they used to be called the chemical straitjackets. It would make it difficult for you to move, difficult to initiate movement. So the lack of dopamine all by itself can mimic Parkinson's disease. So that would be drug-induced Parkinson's syndrome. So I've told you two examples of Parkinson's syndromes that are not Parkinson's disease, but they look like Parkinson's syndrome. They look like Parkinson's disease. So the first one I talked to you about was called vascular or lower body Parkinsonism. And the second one I just mentioned is drug-induced Parkinsonism. In both cases, the picture looks very similar. There's slowness of movement, there's rigidity. In the case of drug-induced Parkinsonism, the big difference is you'll see it in young people. In fact, the drug-induced Parkinsonism that led to insights into the cause of Parkinson's disease was noted in young schizophrenics in the early 1950s who were treated with Thorazine, the first of the major tranquilizers to treat psychosis and aggressive behavior. Those drugs work by making people Parkinsonian, believe it or not. Can you, so there are two dopamine systems that are critical. The one that is the substantia nigra striatal system, which is in the deep gray matter of the brain, and that's the one when there's a problem, there's slowness of movement, rigidity, and Parkinson's syndrome. The other dopamine system is the emotional dopamine, and that goes from substantia nigra to the frontal cortex and to the emotional brain. So anytime you have feelings of well-being, there's a release of mesolimbic dopamine. Anything that makes you feel good involves the release of dopamine. And there are drugs that release dopamine broadly, and they're called psychomotor stimulants because they make you feel good, your thinking gets better, and you move better. So an amphetamine is a psychomotor stimulant. Modafinil, Ritalin. In fact, those drugs, when they were first developed, were used for Parkinson's syndrome, for Parkinson's disease. I heard from people who kind of looked at this that Adolf Hitler, who had Parkinson's disease, there was the era before levodopa, before we knew anything about dopamine, was given amphetamine and supposedly had some benefit from amphetamine. Amphetamine would have very short-term benefit, but in the long run, it's actually destructive to dopamine terminals and can cause psychosis. So you can maybe explain something about Hitler's insanity. So I've talked about two kinds of Parkinson's syndrome. The real Parkinson's disease I'm going to get into in a bit more, because it turns out there isn't just a real single Parkinson's disease. It sounded pretty simple, right? There's Parkinson's syndromes, and Parkinson's syndromes can be caused, the vascular problems can be caused by drugs. They're usually, the drug-induced Parkinson's syndromes are reversible. No other form of Parkinson's syndrome is reversible. Perhaps post-traumatic Parkinsonism, or the Parkinsonism due to normal pressure hydrocephalus. Those get a little better if you correct the underlying pathology. But, so how do I make the diagnosis? Well, first I have to conclude there's Parkinson's syndrome. That's the easy part. Now, how do I know if it's really Parkinson's disease versus this whole range of other variations of Parkinson's syndrome? You've all heard of Parkinson plus, multiple system atrophy, and I'm going to describe those. So far, I've described only two types of Parkinson's syndrome. The one that's called idiopathic or classical, I'm going to spend a lot of time on. But the one that was drug-induced, you understand there are many drugs that we can use now that will cause Parkinsonism. For example, Reglan, used to promote gastric emptying. In some people, it can block the remaining dopamine receptors and cause Parkinsonism. Other major tranquilizers that are even of the newer generation can cause Parkinsonism. So don't use major tranquilizers in Parkinson's disease unless it's the new generation like quetiapine or Seroquel. All of the other ones that are supposedly newer generation can block dopamine receptors and result in a Parkinson's syndrome. So the way I distinguish Parkinson's syndrome from Parkinson's disease is by the response to medication. Remember that in Parkinson's disease, there's a deficiency of dopamine. And if I replace dopamine in those patients, a lot of the symptoms get better, especially the slowness of movement, the rigidity, sometimes the tremor. Balance may improve a little bit, but not great. If the patient takes an adequate dose of levodopa-carbidopa or synthetic dopamine and doesn't get better, then we know it's not going to be Parkinson's disease. It's going to be either lower body Parkinsonism or one of these Parkinson plus syndromes. Now, the problem about Parkinson plus syndrome is that they may respond to dopamine replacement for a little bit, never as dramatic a way as with classical Parkinson's disease. So the way that we make the diagnosis in the clinic is by the appearance of the signs and symptoms that I've told you about, and by the response to medication. Now, you don't want to immediately slap on levodopa-carbidopa to someone who doesn't really need it. You're doing it just to make a diagnosis? No. You really should not institute dopamine replacement until the symptoms that the patient has interfere with function. Because levodopa-carbidopa is a double-edged sword. It's wonderful for alleviating symptoms, but in 3 to 5 years of taking levodopa, people can develop complications of levodopa, which are movements called dyskinesias and wearing off, etc. So we don't want to just rush into levodopa. If you're less than 60, I won't, and you need symptomatic relief, I'll use a synthetic dopamine, a dopamine agonist. Could be either ropinirole, known as Requit, pramipexole, known as Mirapex, or the newer one that I prefer is the patch delivered system of rotigotine, known as Nupro. The reason that 60 is considered anybody less than 60 is young, in terms of the risk of developing the adverse effects. 60 is the average age at which the diagnosis of Parkinson's disease is made in the United States. And people can have the diagnosis at 40 and 30, though those are a little more rare. If I start treating a 45 or 50-year-old with levodopa, by the time they're 43 or 45, they're going to have severe dyskinesias, just like Michael J. Fox had. Muhammad Ali had facial dystonias, and he refused to take levodopa for 15 years because he had such a very fast onset of the involuntary movements caused by levodopa. If you're less than 60 and you need symptomatic relief, and I want, but I won't want to give you levodopa, which would help me make a diagnosis, right? I'll use a synthetic dopamine. And generally, if symptoms improve, then I know this is Parkinson's disease. Nowadays, we have another way to validate the absence of dopamine. That is with the new SPECT scan, which every hospital can do nowadays. It used to be you needed experimental PET scan that would look at the integrity of your dopamine terminals. And now we can do SPECT. But the problem with SPECT is that people with atypical Parkinsonism can sometimes have diminished dopamine fibers also. So that is the most difficult distinction between Parkinson's disease and Parkinson plus, or multiple system atrophy, or atypical. Those three words I said refers to the same hodgepodge of Parkinson's syndromes. So when I say Parkinson plus, multiple system atrophy, atypical Parkinsonism, I'm referring to the following list of Parkinson's syndromes. And one of them is known as progressive supranuclear palsy. And that is a Parkinson's syndrome with slowness and rigidity. It gets a little bit better with dopamine replacement. But one of the little flags, red flags that tell you it's probably not Parkinson's disease, is that they have problems with vertical gaze. They can't look downwards or upwards. They have to go like this, or like this, and eventually they have to turn their head to gaze. Their eyes don't move normally. They have normal reflex movements called bullseye reflex. So if I have them fix on something and I move that back, eyes do move down. When I have them track my hand, they can't voluntarily gaze down. That's called PSP. And if you look at the brains of those people, they have a slight loss of dopamine receptors, but they have a pathology involving those neurons where dopamine acts. In other words, the problem isn't with the key, it's with the lock. Remember, dopamine is nothing but a key that fits into cells that have a dopamine receptor, that would be the lock, and allows for you to walk through the door. If you have a problem with not only the key, but also the lock, I can give you the key and you might occasionally get through the door, but eventually the problem with the lock, the door, is all messed up. So that's how you can understand atypical Parkinson's syndrome. They usually have more than just nigrostriatal lesion or loss. So in the PSP, what happens, they don't even have Lewy bodies. So they're really different than Parkinson's disease. It looks just like it. They have the small steps, decreased arm swing, rigidity. But they have a lot more axial rigidity. Their necks are really stiff, and they can't voluntarily gaze. And they have a harder time going down the stairs because they can't look down. They can't gaze down, so they can fall going down the stairs. Going up is not so bad. So what's the pathology, fascinating pathology it is, because this is one of the first atypical Parkinson's syndromes described. Originally, you're lucky we don't use the name anymore, but just to show you how we went overboard in naming diseases in honor of the doctors who first described them, was Richardson, Steele, Olszewski. It would have been just Richardson, Steele, we'd remember it, but when you have to write out Olszewski, forget it. So it's called progressive supranuclear palsy. The reason it's called that is that there's a gradual progression of difficulties with vertical gaze. Vertical gaze palsy, progressive supranuclear palsy, and it's mediated by frontal lobe centers, frontal eye gaze fields that will drive the eyes down or up voluntarily. Well, they're disconnected and you can't voluntarily gaze. But the pathology, interestingly enough, looks like the pathology of people who died with encephalitis in the 1920s, and that was another cause of a Parkinson's syndrome, by the way. It's called post-encephalitic Parkinson's syndrome. It's very, very common after the epidemic in the early 20th century that killed millions and millions of people. Survivors of this, it was called the sleeping sickness. It was a terrible brain inflammation caused by a virus. It's not clear what the virus was. It was believed to be one of those horrible flus. Quote, Spanish influenza is what they used to be called. But they develop what looks like a pathology that you see in Alzheimer's disease, but localized to the brainstem. It's called neurofibrillary tangles, where the nerve fiber proteins form weird, twisted, abnormal fibers. And you see that kind of pathology in Alzheimer's disease, but not in the brainstem. In Alzheimer's, that pathology is found in the higher centers, the cerebral cortex, which is responsible for higher levels of thinking and association. But in PSP, progressive supranuclear palsy, you'll see that pathology of neurofibrillary tangles, which is typically, you think of Alzheimer's, but it's localized to the brainstem. And yet, clinically, it's not that unusual. I see people with Parkinson's syndrome. They've been diagnosed with Parkinson's disease. They did well for a few years on Cinemet, and they come in and they're falling, and they look like they have much more advanced disease. It's hard to get much benefit from the Cinemet anymore. And then I see their eye movements. That's the diagnosis. And we can also confirm it with MR from the mid-sagittal. You can see some shrinkage in the midbrain that's unique to PSP. So that's one in which we can distinguish from Parkinson's disease, even though in the beginning they both get better with levodopa. And with PSP, if you did that scan that I said now, unless you look at the integrity of dopamine fibers, they also have a diminishment of dopamine fibers, but they have this other pathology that affects the response to dopamine. And so after a while, they don't respond to medication. So there are two other major types of atypical Parkinsonism. There are many, but I'm going to talk about common, relatively common. So the other one is called multiple system atrophy. And there, when one examines the patient, there's slowness of movement, rigidity, tremor. They get better for a while on Cinemet. And if you did a scan, they'd have a deficiency of dopamine. And it looks like Parkinson's disease. But when you do the exam, you notice a few other features. Number one is a hyperreflexia, where the reflexes are extremely brisk. It's the kind of reflexes you see when there's been a stroke. In other words, there's a disinhibition of reflexes. So if I tap the knee, the leg really shoots out, or the arm shoots out. And that means that there's what's called an upper motor neuron sign, in addition to the Parkinson's syndrome. And they tend also to have a problem with the autonomic nervous system. So when the autonomic nervous system is really much more involved, the autonomic nervous system uses chemicals like dopamine, called noradrenaline, which is a cousin of dopamine. They have a lot of low blood pressure. They sit up and they almost pass out. They sweat and feel cold a lot. Things that Parkinson's patients have, but in this bad form of multiple system atrophy, it's known as Shy-Drager, and the two neurologists who describe it, where the autonomic nervous system findings, and I'll go through the list of all these, they're all non-motor features that we see to some degree in Parkinson's, but in Shy-Drager multiple system atrophy subtype, called MSA-A for autonomic, they have really much worse constipation, much worse problems with urinary bladder function. The hot and cold feelings are very dramatic. And the biggest issue is lightness of head upon standing. They can't stand without almost passing out. So we have to give them blood pressure increasing medication because they have what's called orthostatic hypotension. Now, many people with Parkinson's disease have little elements of the autonomic nervous system involved. There's no doubt. Constipation, bladder, lightheadedness if you get up too quickly, partly because the medicines that we use, like levodopa, dopamine, lower blood pressure a bit. But in the Shy-Drager, it's very, very pronounced, where the autonomic nervous system problems are much more involved than the slowness and rigidity. Then there's another form of multiple system atrophy. Now, you say, how do I make a diagnosis of Parkinson's disease? Just like James did, just observing and doing an exam. That's Parkinson's syndrome. And then by giving them a drug, I can tell if they have a dopamine deficiency. And that's as far as we usually go. But about 10% of cases have these atypical forms. So the other atypical form that isn't as common as Shy-Drager or PSP is one in which the problem is cerebellar ataxia. Now, this is an interesting concept for you because I rarely talk about it, but there is a form of Parkinson's syndrome, atypical Parkinsonism, known as, again, it's a mouthful, OPCA, meaning olivopontocerebellar atrophy. So not only is there nigrostriatal dopamine loss, so they get a little better, but they have a cerebellar pathway problem. And what does the cerebellum do? These are deep gray structures in the base of the brain that have tremendous connectivity with the deep gray structures that involve movement, and also connectivity with the frontal lobes. The timing and rhythm are modulated by the cerebellar pathway. So people who have cerebellar disease If it's in the middle of the cerebellum, they have terrible ataxia of gait. They have terrible balance, and that's the predominant symptom. So people who are excessive alcoholics, they'll just develop cerebellar ataxia, wide-based gait, as opposed to the Parkinson gait, which is narrow. An ataxic gait is wide-based, and they bounce. And when they reach for something, it's great big. And unlike the action tremors, this is. And so the sense of rhythm and timing is way off. And there's no medication that's going to improve timing and rhythm in cerebellar diseases. Those are called cerebellar ataxia. So there is a variation of Parkinson's syndrome that has slowness and rigidity plus cerebellar ataxia. That's called OPCA. And there's an interesting kind of Parkinson's syndrome that really is Parkinson's disease, but the dementia far outweighs the slowness and rigidity. That's called dementia with Lewy bodies, where the pathology is the same as for the run-of-the-mill Parkinson's disease. They have these Lewy bodies, but they have spread to involve the higher thinking areas, the cerebral cortices. So they'll present with visual hallucinations, confusion, disorientation, that mimics a little bit of Alzheimer's disease. But then when you examine them, they also have some slowness and rigidity. Typically, it looks like it's a very distinct cognitive profile from Alzheimer's disease, but it has to be assessed by a neuropsychologist who give a series of cognitive assessments. The problem with treating dementia with Lewy bodies with anti-Parkinson drugs is that the anti-Parkinson drugs make their dementia worse and can worsen the hallucinations. So before you can even begin treatment with Cinemet to see if they really will respond in terms of slowness and rigidity, you have to protect them against these potential psychiatric side effects of levodopa, carbidopa, and that is to use quetiapine or Seroquel. Make sure they're sleeping at night, they have no more hallucinations, then you can introduce levodopa, carbidopa. And typically they do have a deficiency of dopamine and they'll get a little better in terms of their movements. But you have to be very careful. If you increase that anti-Parkinson drug too much, you develop a psychosis. Which brings us back to the 1950s. We were treating psychotic patients with tranquilizers, and the tranquilizers are nothing but powerful antihistamines, souped up antihistamines. You know what an antihistamine is. The most common is Benadryl. Many people use it as a sleep aid. It does have slight sedative effects. And that Benadryl was modified chemically by adding a few structures to it. And it made a very powerful antihistamine that had incredible tranquilizing effects. So you could tranquilize a violent animal, aggressive animal with this stuff. And they began to try to treat aggressive paranoid schizophrenics with it, and it worked dramatically. These people used to be in straitjackets in psychiatric state hospitals. Once the phenothiazine, you may have heard of it as Thorazine, that was the first brand name. It opened the doors of the psychiatric state hospitals because people could go home. If they continued to take their Thorazine, they were fine. The biggest problem is many of them developed Parkinsonism in their 20s and 30s. And it was the work of Carlson who began to study how Thorazine caused Parkinsonism. He discovered it was reversible, that it interfered with dopamine action, and then he measured dopamine in Parkinson's brain. So think of what schizophrenia is. There are many drugs that can precipitate a schizophrenic psychosis, including levodopa. In fact, there's a dopamine hypothesis of schizophrenia because all anti-schizophrenia drugs, antipsychotic drugs, block dopamine, but the emotional dopamine. And it's hard to just block the emotional dopamine without blocking the motor dopamine. So when you treat schizophrenia, you can end up with a movement disorder, Parkinsonism, or if you treat a movement disorder with levodopa, you can end up with a psychosis. That's why many of you are aware that I prescribe a lot of Seroquel to protect against the psychiatric side effects of dopamine replacement. Now, fortunately, we have drugs that will block just the emotional dopamine without affecting the nigrostriatal dopamine, and that's what quetiapine will do. So I use that quite frequently. No one in their right mind would use classical tranquilizers in a patient with Parkinson's disease. Every now and then I see that in a nursing home. someone with Parkinson's disease, dementia is really acting up, has got aggressive, and they put them on Haldol, which is a major, and that's a disaster. That's a real disaster. It's actually life-threatening. So I think I can take questions, but let me just, in a nutshell, summarize, because this is a lot of material, even for people who are experienced with Parkinson's disease. The diagnosis, that's what we're talking about. The diagnosis is made by family members, by community doctors. Doctors walking in the street, well, I see all the time, I see a patient, and my mind is, oh yeah, this is a Parkinson's patient, must belong to Dr. Z, because I don't recognize the patient. But, so Parkinson's syndrome is easy to recognize. Slowness of movement, rigidity, rest tremor, and loss of balance. And because of those cardinal signs, they have some secondary signs. And that's what we really go by, how they move, how they slouch, facial expression, eye blinking, etc. How to distinguish Parkinson's syndrome from true Parkinson's disease. First step is dopamine replacement. If they get a lot better in terms of slowness and rigidity and movement, then it's probably going to be Parkinson's disease. But then you keep your finger crossed. You hope they continue to have good response, because if they don't, it may end up being an atypical Parkinson's syndrome, which will require a little bit more testing. So I'll take questions.
How about Ambien?
Well, Ambien is a minor tranquilizer. So I keep on saying major tranquilizers is a class of drug that typically is used for psychosis. No one uses Ambien for psychosis. Ambien is a minor tranquilizer. The grandparents of the minor tranquilizers is Miltown. Many of you remember Meprovamate was the popular drug used in the suburbs for anxious housewives. Then that soon led to the benzodiazepines. The first one was Valium and Librium, and we have about 10 of them now. If they're slightly longer acting, like Ambien, we use them for sleep, because they're anti-anxiety drugs, but also sedative hypnotic, and also muscle relaxing. So we use them for a number of conditions. The downside of Ambien, Valium, Librium is that in Parkinson's disease patients who have a tendency to be depressed, it worsens depression in the long run. So I never would recommend Ambien as a sleep medicine other than for a week at a time. Or if you're going to take a transatlantic trip, then take Ambien to sleep on the plane. And always with someone, because it can cause strange after effects. So yeah, Ambien is a minor tranquilizer prescribed as a sleeping pill. Other questions?
Have you ever noticed?
Let me do this. I'm going to give you guys a microphone so everybody can hear, okay?
Have you ever noticed a change in symptomology due to weather with your patients?
Yes. I also noticed it just as the moon, with the moon coming out, full moon. No, it's actually, it's true.
I know.
And planetary alignments. No, but it's subtle. It has to do with the fact that this is not just a slowly progressive disorder. It gradually changes as we age. But from moment to moment, there's changes. The biggest change will occur if there's an intercurrent illness, like a pneumonia or bladder pain. Then there will be a big decompensation. The symptoms get terribly bad, and they call the office and say, why am I so bad? But there are these subtle day-to-day changes, just that reflect your day-to-day moods. Like some people are very, I'm thinking of my daughter, who's very emotionally labile. Some days she's so euphoric and happy, other days she's down and the world is a disaster. So if she had Parkinson's disease, well, those moods would translate into a really bad case of Parkinsonism today. Whereas yesterday when I was feeling more optimistic, hey, it's not so bad. Look at this, I'm going bowling with my friends. You know, so yeah, mood is very critical. And that's another reason it was called a neurosis, because it was noted in the 19th century that people who had Parkinsonism would be a lot worse under certain emotional stresses.
I've noticed the symptoms are worse if we get sudden onset of cold weather, or the humidity goes up all of a sudden.
Yeah. Well, I can understand. Yeah, absolutely. The cold is absolutely one of the worst things, because it'll make everyone rigid. I mean, that's what you do.
You're iced.
Yeah, no, you just get stiff and you shiver, and you know, so cold is the biggest enemy of Parkinson's disease I can think of in terms of weather changes. Extreme heat is not so great, but the heat is better for the rigidity, because with warm environment, you can the rigidity is less. So It's just the excess heat and humidity versus excess cold. Ideally, you should have a medium range of climate changes, climate conditions.
I believe you spoke about cogwheel rigidity. Is there anything that can be done to return that person to more?
Yeah, dopamine replacement. That's the first thing that we'd see improve, is the rigidity. That's what the drug is for. It's really amazing how that's the first thing I look for. And a lot of patients are looking for to relief of tremor. They'll say, "Yeah, doctor, he still has a tremor." When I see the rigidity's gone, I say the most important thing is the rigidity, because that interferes with the speed of movement. Whereas the tremor sometimes is the last thing to respond to dopamine replacement.
But from what I've seen is that there isn't just one thing that we can point to of so many things you spoke about. There are more than one involved.
Well, this is why I spoke to you about the cardinal signs and symptoms. Those are the things we want to see and examine, because everything else is secondary to that. So for the rigidity, that is the thing that responds to best dopamine replacement, unless they have PSP or an atypical Parkinsonism, in which case the problem isn't the rigidity isn't just due to dopamine deficiency. Rigidity can be due to stroke, a whole bunch of other neurodegenerative conditions, MS, demyelinating disease. There's a lot of stuff that can cause rigidity. So if a person is given the diagnosis of Parkinsonism and they have rigidity and dopamine replacement doesn't affect that, they don't have Parkinson's disease. They have an atypical form.
And PSP, how is that scanned? How is that done?
They do the same way. It's Parkinsonism. You just know what those 4 cardinal signs. Everyone should recite them to me together, like in class. Slowness of movement, rigidity, rest tremor, and balance. Now, in PSP, you have all 4, but they have in addition problems with vertical gaze and eventually horizontal gaze. And their response to Cinemet isn't long lasting. It would be good for a couple of years. And then and they have more rigidity in the neck and axial
So
muscles.
the head stays down?
No, not necessarily. If anything, their head is like this so that they can see where they're going. They tend to have a quizzical eye openness like this. They don't tend to be like that. They're a little different.
I see.
And they won't respond after a few years to dopamine replacement.
So with what I've learned today, I should consult with the neurologist about it?
You should always consult with a neurologist.
Yeah, but you know, sometimes we have to point things out because we are the caregivers and we see what happens.
So you have a patient with Parkinsonism that doesn't get their rigidity improved. Is that what you're saying? Well, then it's either the dose is inadequate or they don't have Parkinson's disease. Rigidity is invariably improved with dopamine replacement unless they have the multiple system. Like the MSA, the upper motor neuron, they have spasticity and hyperreflection. Spasticity is also causes rigidity. There are disorders that are frontal lobe atrophies also have rigidity called Gegenhalten rigidity, counter-resistant, very different than Parkinson's rigidity. So who examines the patient you're talking to me about should look at the types of rigidity that are there.
Well, we're dealing with NPH as well, so
Oh,
it's not just.
well, if it's NPH, then I've never seen a case of NPH and Parkinson's disease. NPH is a lot like lower body Parkinson's. It affects the gait,
Yeah,
there's rigidity, but the upper extremities are not as, their
Right.
arms tend to be
it's
like
the lower extremities.
Yeah,
Yeah.
and it's the same mechanism that causes the gait problem in normal pressure hydrocephalus is the same mechanism that causes lower body Parkinsonism, because there's an undercutting of the white matter pathways from frontal lobe down to the basal ganglia. In both normal pressure hydrocephalus, because the ventricles are so big, stretching out those fibers, or ischemic changes that interfere with those fibers. They look very much the same, but the difference is that normal pressure hydrocephalus tends to have a lot more dementia than, let's say, lower body Parkinsonism. Though they both can, because if you have a lot of small vessel occlusions, you can get a dementia. In the early 20th century, called arteriosclerotic dementia. So you can get Parkinsonism and dementia with lower body, with microvascular disease, with poor blood flow to the brain. Normal pressure hydrocephalus is treatable by shunting, and so you can't even talk about Parkinson's disease until you clear up the normal pressure hydrocephalus, because it mimics some aspects of Parkinson's syndrome. There's, she had, back there, she's been patient.
Hi, how do you differentiate MSA-C cerebellum with OC?
OP, the same. It's just the OPCA is the older terminology.
That's exactly.
That's the older terminology, it's exactly the same, and they both can be distinguished from Parkinson's disease because you'll see atrophy of the cerebellum and the pons. These are structures of the brain that shrink in OPCA or MSA-C.
That's
MSA is multiple system atrophy cerebellar type, which is the previous name to that. It was called olivopontocerebellar atrophy because those structures are shrunken.
I had DBS.
Say it again, no one heard what you said. You just have to speak into the scope.
I had DBS done about 3.5 years ago. What should I have expected from the result of that surgery?
Everyone understand the question? What should I have expected from the DBS that I had? First of all, DBS is something that not everyone would benefit from. But DBS should be reserved for individuals who have complex motor fluctuations in response to levodopa. That's the only reason that you should have DBS. In other words, in order to do the DBS in a patient with Parkinson's disease with complex motor fluctuations, they have to come in to the clinic without any medicine that morning, since last night. They are given a challenge dose of levodopa, carbidopa, and if they improve by 30% in their motor function, and their motor function wears off very quickly, every 2.5 to 3 hours, and they have dyskinesias in between, that would make him a good candidate. And so what would you expect? You would have less motor fluctuations, you'd be on more, and you'd have less dyskinesia. And you might be able to decrease the levodopa. That's what you can expect. What you can't expect is improvement in gait and balance and in speech. And you can expect some decline in intellect as well when you have these electrodes put into your brain. But what you can't expect is improvement in gait and balance, because there's nothing that this DBS that we do for slowness and rigidity and for motor fluctuation will not impact gait and balance. And it won't, and in fact, bilateral DBS tends to affect voice more than was ever anticipated. So unrealistic is to think, I have Parkinson's disease, I'm going to have DBS because that's the latest technique. Hogwash. DBS and surgery for Parkinson's disease has a long history. Since around the 1950s, if not earlier, they were making lesions in the brain to try to attenuate tremor or rigidity. And it was given up because levodopa came into existence. So in the 1950s, there were tens and 30,000s of individuals in New York that got thalamotomies and big holes, maybe 1 centimeter to 2 centimeters, put into their brain because some of the symptoms were improved temporarily. And that fell into disrepute because levodopa was much more of a magical drug. Didn't have to have surgery, and it was much more effective against slowness and rigidity. The only reason that surgery came into play again, it's complicated, but simply because levodopa in 50% of patients within 3 to 5 years causes complex motor fluctuations. Now, there are ways to control that without surgery. And so my view as a pharmacologist is to use long-acting dopamine agonists and do everything I can, including encouraging physical exercise, before I would even think of sending you to for deep brain stimulation, because all they would be able to offer is smoothing out of your response to levodopa. You still need to take dopamine replacement. You still have a balance problem. However, if you're a young person, 35 years of age, with really horrible roller coaster ride day to day, then DBS would be very good. And you can expect improvement in daily function. One more question, because there's one way over here.
Do many of your patients on Nupro find the application site painful?
No. What they do is they'll find it itchy, it'll get a rash, and you have to now go to that site for 10 days or 14 days.
Just the site itself is painful?
No. Now, if it's painful and you take it off, you see blisters, then you're allergic to it. But itchiness and redness, It's very common, that's why you rotate the site. And you put 1% steroid cream, cortisone cream there. You're going to be back to that site in 10 days, so it's within a few days that issue. So I've never heard of anyone saying it's painful unless you get direct sunlight on it, or you get an MRI with it on it.
Laying on that side with the patch. Okay.
But I don't understand that. It may be some other underlying reason for the pain.
Just
But,
sort of.
yeah. Okay, well, thank you.